Hi, I'm Anita Palafu. I'm one of the internal medicine doctors at St. Paul's Hospital, and I'll be hosting most of the Own Your Health sessions, which are community forums that we decided to start doing. We've done a number of them over the last few months, and we're going to continue on into the new year. And I'm delighted tonight to have our session be Let's Talk About Eating Disorders, and we have a great panel of speakers to join us today. So thank you for braving the cold winter weather. I feel like hibernating when the sun sets at about 4 o'clock. I'm impressed that anyone leaves their home because it's cold, rainy, and dark. It feels like it's 9. So thank you for coming out, and we've got a great set of speakers. So I'll just introduce, we're going to, I think, have from the psychiatry group come up first. So we have Dr. Samantha Kelleher and Julia Rauzus, and they're specialists in psychiatry in the Department of Psychiatry at St. Paul's Hospital. And they both work in the eating disorders program, and they provide care to patients throughout BC. And St. Paul's Hospital is the home for this provincial program of eating disorders, and we have a great deal of experience in this area. And they provide care for both the inpatient and in the outpatient units and in the clinic. And they're also very active in imparting their knowledge and expertise to medical students as well as residents to build the capacity in this area. And they'll also introduce the internists who are more my immediate colleagues, Dr. Jane McKay, Dr. Ric Arseneau, and Dr. Debbie Rosenbaum. And they're all general internal medicine specialists in the Division of General Internal Medicine at UBC and at St. Paul's. And they're actively providing care in internal medicine for the eating disorder population who have internal medicine problems throughout BC as well. They provide advice and consultative medicine support to the program. And they also are available to people who are in the province who need their expertise and advice. So it's, again, a provincial program that we offer out of St. Paul's. So I will step away. And the way the format is we're going to have the two sets speak, and then what I'd like you to do is if you have questions, we're going to have you write them down, and then they'll get passed to me, and then I'll kind of moderate the question and answers, and they'll sit up here and answer your questions. This way you don't have to put up your hand, and because sometimes people ask the same questions, and I can try to interpret them. So I'd ask you to write down one question at a time, and secondly, make your printing as legible as possible and as clear as possible so I don't have to interpret it too much, okay? And I will pass it on to Samantha. Thank you.
Thanks. So hi, I'm Dr. Sam Kelleher. I'm one of the psychiatrists in the eating disorders program here at St. Paul's. And I'd just like you to know who the rest of my colleagues are, because not all of us are going to speak. And at least one is going to have to leave probably a little bit early. So Julia Rauzus is here, one of the psychiatrists. And Debbie Rosenbaum is one of the internists. Dr. Jane McKay, another one of the internists. And then you'll hear from Dr. Ric Arseneau, who's the other internist. So we have a very comprehensive team of people who treat patients throughout the province for eating disorders here at St. Paul's. And what we wanted to do is go over a little bit about what we do and about what eating disorders are. So I'm going to start first from a psychiatric perspective, taking you through what eating disorders are, what kinds of things we do when we assess and treat patients. And then Dr. Arseneau is going to come up and he's going to talk to you about what some of the medical complications and how medicine helps us to treat our patients. So this is who we are. And so, first of all, I'll tell you the role of the psychiatrist, because sometimes people think, well, if this is an illness that affects people so medically and makes them so physically unwell, how does a psychiatrist play a part in this? Well, really, the diagnosis of eating disorders falls to psychiatry to make, and there is a lot of cognitive and behavioral aspects of it. So in terms of the treatment, we see ourselves as sort of the point person who does the initial assessment, and we do a thorough assessment and make diagnoses of eating disorders. We collaborate with our internal medicine colleagues, and we are quite unique in our program here because we do have internal medicine specialists who work with us all the time and who assess our patients and provide the highest level of medical care. There's many programs that exist that do not have internal medicine attached to them, so the medical component would fall to either the psychiatrist or a GP to manage. So we're very fortunate here that internal medicine is so involved with us. We also collaborate with all other team members. So we work with nurses, we work with dietitians who help our patients with renutrition. We have occupational and recreation therapy, help our patients look at what their lives are like and how to improve their quality of life. We have pastoral care that also helps people address the spiritual needs and help them look at what they would like to gain in their lives. And we also have psychology, who are really involved in outpatients and in the day program that we have. When we look at treatment planning for patients, we think about a very comprehensive treatment plan because we know these are very complicated disorders that really need to be approached from a variety of angles. So when we look at treatment planning, we think about inpatient settings, outpatient settings, as well as day program settings. The other part of our assessment includes assessing people for other illnesses that might coexist with eating disorders. So a number of our patients have things like mood disorders or anxiety disorders. Some people have substance use disorders. And so part of what we do in assessing them is assess for those things so that we can treat those as well. So when it comes time for assessment, when our patients come to see us, they're referred by either a family physician or through a regional eating disorders program. So those are throughout the province, and everywhere except for Greater Vancouver has regional or secondary programs. So people are referred through those sources. And when they're seen for assessment, they're seen by usually Dr. Rauzus or myself for a psychiatric assessment, or Dr. O'Kane, who's another one of the psychiatrists, and then one of the internists for a medical assessment. They also participate in a research assessment because our program is very involved in research and looking at how we can improve outcomes and how we can improve our program. So the patients come for this quite a comprehensive assessment. In terms of the psychiatric piece, we talk to patients about how things started with their eating problems, how long they've been there, and try and get a very detailed description of what's going on, whether it's more restrictive or whether there's more binging and purging behaviors happening, and trying to get a really, really detailed understanding, which at times can be very difficult because people come with a lot of shame and a lot of distress about revealing those things. So we try to approach that in a way that says we just want to be able to help. So the more that we know, the better we can do that. So most of our information comes directly from the people that we see, but we also collect additional information, sometimes from family members and oftentimes from other care providers, so regional programs or other psychiatrists or physicians who've been involved with our patients. We also gather other information such as things like what medications people have been on and whether they've been hospitalized, because again, that just fills out the picture for us about what's been happening. And then in our assessment, we also consult with internal medicine. And typically, you know, if, say, Dr. McKay and I both see the same person for assessment, we usually try to touch base that day if we see that person on the same day so that we're both on the same page about what we've seen and what we think is going to be helpful. When we look at the diagnoses that eating disorders encompasses, we really think about three major diagnoses. So anorexia nervosa, which is a diagnosis that includes people maintaining a very low weight, and in females that their hormones get so disordered that they lose their menstrual periods. And then bulimia nervosa, that really involves binging and purging, and people are typically of normal weight. And then eating disorder not otherwise specified, which is not a less severe illness, and probably about 50% of our patients fall into the eating disorder not otherwise specified category because our criteria are such that patients don't necessarily fall neatly into one or the other category. So there's a lot of overlap in eating disorders, and there's a lot of people whose bodies are resilient enough that maybe they're at a very low weight, but their periods haven't stopped. So technically they don't meet the full criteria for anorexia, but they have a very severe illness. So the EDNOS category doesn't mean that it's a less severe illness. It just means that it doesn't fall neatly into one of the other categories. But what really are eating disorders? Because diagnoses are one thing, and that helps us to be able to classify it. But when we look at eating disorders and we think about what do they actually do to people, they affect how a person sees and experiences him or herself, about how they see their body and what they look like. A lot of people with eating disorders have very distorted images of what their bodies are. When they're asked to draw an idea of what their bodies look like, it's usually way out of proportion and much larger than what they really are, even when they're very low weight. It also is, there are disorders that affect how people can regulate emotions, and oftentimes the behaviors of eating and the eating disorder are the things that help them express their emotions or deal with emotions. And eating disorders also interfere with how people interact with others. You can imagine if you have bulimia nervosa, and part of that is, binging and purging repeatedly through the day. It makes it very hard to maintain relationships with people, to be able to be out and working and gainfully employed. And lastly, and Dr. Arseneau is going to tell you a lot about this, is that these are disorders that really affect a person's physical health. There are profound physical changes that happen in the bodies of people with eating disorders. What eating disorders are not, they're not really about food. Food becomes a vehicle, it becomes a mechanism for expressing distress, for working out conflict and control and all kinds of things. It's not about someone just not eating enough or eating too much. It's really about what underlies that. It's not a matter of self-will. It's not just, well, if you would just do this, everything would be okay. It's not that simple. If it was that simple, our program wouldn't exist. We'd be able to hand people a sheet of paper and say, okay, this is what you need to do. They would go away, they'd get better, and that would be great. But that's not the way it is. It's not about vanity. Most of our patients, they don't seek necessarily the image of a model because they think that that's beautiful. They seek that because it might be perfection, it might be about control, it might be about a whole lot of other things. It might be about wanting to disappear. So it's not about vanity, and it's not a harmless phase. It's not something that, you notice that someone's lost a lot of weight or that their eating patterns have changed. You go, okay, well, that'll go away. That's not a big deal. It's not a harmless phase. It's very dangerous. So who develops eating disorders? So women represent 90 to 95% of patients that we see with eating disorders. There's suspicion that the numbers in men are higher, but they just don't come for treatment, and men tend to look a little bit different than women with eating disorders, although there are a number of men that we see that are very, very typical as to what we see in women with eating disorders. Has anyone ever seen the movie Pumping Iron? Arnold Schwarzenegger, his last run at Mr. Universe? For me, that's an example of what eating disorders look like in men. If you watch Arnold and you watch the other guys, they restrict what they eat, they train like crazy, they wear heavy clothes while they train, they restrict their fluids, they do all kinds of things that are repeatedly doing damage to themselves. And then at the end, they actually are quite excessive in their celebration. It's a really interesting film because it shows you how really quite psychologically minded Arnold is, as he sort of fakes out Lou Ferrigno. But anyways, it just gives you an example of how eating disorders in men can present very differently, that it might be more about bulk and shape and definition than it is about maintaining a low weight. The onset occurs typically in adolescence and early adulthood, so you can see it's a time where people are developing their sense of self, where they're starting to move into school, college, university, careers, so it's a time where things get really disrupted. When looking at the numbers, bulimia nervosa can affect up to about 5% of women, and anorexia about 1% of women. So what causes eating disorders? Well, there's not one cause, and there's not one way of thinking about any one person or any group of people with an eating disorder, because there's so many different variables. So we know there's a genetic predisposition, and there's a lot of work being done these days on what exactly are the genetics of eating disorders, but we certainly know that they occur more frequently in monozygotic twins than dizygotic, so twins that come from the same egg rather than twins that come from separate eggs. That they seem to run in families, and there may be cultural components and there could be genetic components in that. We also know there's sociocultural influences, so those can be influences within the family themselves and their own cultural beliefs, and then the greater society because we know about the images that women are bombarded with all the time, and men are bombarded with all the time now about what perfection is and what we're supposed to look like or be like, and how to be successful and happy is equated often with being thin. There's a lot of personal characteristics which may predispose someone to an eating disorder, things like perfectionism and obsessiveness, and looking at periods of change. So, as I said, adolescence and early adulthood, times where people are changing. They're moving from, I didn't have middle school, I had junior high school and then high school. So they're in that stage, moving from one kind of education to another, or they're moving from high school into university, times where there's different expectations being placed on them. And oftentimes there is a stressful life event, a loss, an assault, an accident, something that happened that has triggered the eating disorder, at least in part. So in looking at risk factors, we look at things like family history. So again, eating disorders do tend to run in families. So when we see people for assessment, we ask them about eating disorders within the family. Parental obesity has been found to be a risk factor, as well as things like restrictive dieting within the family and concerns about eating, appearance, or weight that are prominent within the family. In looking at personal history, patients who have had body dissatisfaction from a very early age, who have engaged in restrictive eating, and dieting is a big trigger for eating disorders. Childhood obesity, which then can lead to dieting and on to an eating disorder. Early onset of menstrual periods, and again, changes in body is something that young women who are developing are very sensitive to, and that can be a trigger, and that can be a risk factor. Can't do a whole lot about that. Depression, substance use or dependence, and anxiety disorders are also risk factors, as well as any adverse life events. So personal characteristics, as I mentioned, things like perfectionism. So, the young person who always wants to get A's, who always wants to do everything very perfectly, who has very high standards for themselves, may not be coming from outside of themselves, but internally have very high standards, are at higher risk. And if they have obsessional traits, so kind of get stuck on things until they get it just right. Alexithymia is a term that means people who have difficulty in feeling and expressing their emotions, so they really can't put a name to their emotions. That seems to place people at higher risk. And again, thinking back to what eating disorders are, they affect how people experience emotion. So you can see if someone isn't able to do that, their eating disorder may be the way that they experience emotion. And low self-esteem is also another risk factor. And under other, so being a woman is a risk factor. So again, it's one of those risk factors that you can't really change. And occupational status or involvement in a sport that really emphasizes body weight and shape. So we think of the typical things like ballet, gymnastics. But one of our other psychiatric colleagues, Dr. Leslie Cohill, wrote a letter to the editor of The Sun last year, and it was in regards to the restrictive eating patterns in male ski jumpers. Was it male ski jumpers? Yeah. And sort of this idea that, they were being encouraged to eat very little, to smoke when they were hungry and keep their weight down. So, just because then you're lighter and you can jump further. So she wrote a letter sort of saying that this was very dangerous. Okay, so what are the signs of an eating disorder? So in seeing someone who you love or care for or know, the things that you might see when someone has an eating disorder is dieting, weight loss, or fluctuations in weight that seem to, occur over fairly short periods of time. If you notice an overemphasis on weight and shape as the way that person sees themselves and the way that they see themselves as valuable. There may be physical changes that you can see, such as people becoming pale. They may be anemic. If they give up red meat or different sources of iron, their hemoglobin may be low and they might be quite pale. They often will lose hair, so seeing thinning hair in someone who used to have nice, thick hair is also another sign. If you notice changes to their teeth, when people purge, they can do a lot of damage to their teeth. So you may see chipping or wearing away of teeth or discoloration. And some people will also get swelling in the glands of their face. So a change in their face shape may be something that indicates an eating disorder. And other physical symptoms, so someone who starts fainting all of a sudden or who is complaining of a lot of fatigue, those would also be common signs or symptoms of an eating disorder. Also, if there's unusual eating behaviors, and that sounds like kind of a broad term, and it is because there are so many different ways that that can manifest. So things like people who might pick at their food and spit it out without swallowing it, people who eat really quickly, if there's significant changes in eating behaviors, things like not being able to sit at the table but wanting to stand to eat, or just having very small amounts, or eating foods in certain ways. There's all kinds of different behaviors that might exist around eating. And if there's changes in activity or preoccupation with exercise, so, we all think that a certain amount of activity is healthy and keeps our bodies working well, but the person who becomes preoccupied, the day is not done until 2 hours has been put in at the gym. And it's not about enjoying it, it's about it just has to be done or else they can't go on. That kind of preoccupation can signal that it might be an eating disorder. So how serious are eating disorders? They're really serious. In terms of mortality, so the death rates, they're the highest among all the psychiatric illnesses because of medical complications and suicide. So it's an illness that we really worry about, and particularly because it's young people who develop it. And in the first few years, people can have very severe illness and be at very high risk of death. And then they can go into a phase where they're sick but stable for a long period of time, and then the medical complications can really start to compound themselves and again have, an increased risk of death at that time. There's high rates of ongoing illness, and Dr. Arseneau is going to talk about sort of how many people recover, how many people get better, but certainly the recovery rates are below 50%. So many people go on to have chronic illness. It also takes a very long time to achieve recovery. So for a lot of people, it can take several years for them to fully feel recovered from their illness. There's also very high rates of depression, anxiety disorders, and substance use disorders that accompany eating disorders, which makes treatment, again, very comprehensive and a bit more complicated. It's kind of like, I compare it to someone who has high blood pressure, and someone who has high blood pressure and not much else, they may respond to fairly simple treatment. But the other person who might have diabetes, then their treatment becomes more complicated because their high blood pressure and their diabetes interact, and their treatment needs to reflect that. So when we see patients with eating disorders and anxiety, their treatment can sometimes be a bit more complicated because it has to take into account how those two things interact. So what else is affected? And I've really made reference to all these things as I've been talking already. So there's a disruption in normal development, particularly when people develop their eating disorders very young in life. We have seen growth retardation. We've seen people whose height remains quite small, that they look pre-adolescent, even into their 20s. They might never, if it's a young woman, they might never have even started to menstruate because their bodies just haven't developed enough that they can't do that. We see that some of our patients have an inability to engage in meaningful relationships because everything gets disrupted at a time where people are really trying to figure out who they are and engage with their peers. We see a lot of dysfunction within families, and we see a lot of isolation. So the eating disorder becomes very all-consuming for people, and it becomes about engaging in the eating disorder behaviors, which leaves very little time for anyone or anything else. So when we treat eating disorders, as you can gather, it's multifaceted. There's a lot of people involved, and there's a lot of places where people can get treatment. So there's a number of patients who will be treated quite adequately by their family physician who might be very aware of eating disorders and know of appropriate resources. There's a lot of community resources that are available, particularly outside of Vancouver proper. There's a number of different regional programs that exist. There's our program here at St. Paul's, as well as the Provincial program at BC Children's Hospital. The Kelty Resource Centre is situated at Children's Hospital, and it's a mental health resource, and they have a lot of eating disorder resources within that. So they have an online resource available where people can find out where treatment is available and how to access treatment. There's a number of self-help books, and some of them are very good. There's very good evidence for cognitive behavioral therapy in patients with bulimia nervosa, and so using a self-help book that is based on cognitive behavioral therapy can be very effective for people. And then there's outpatient therapy that can be provided in a number of different settings. So when we look at it from our perspective and how we treat patients, there's psychiatric care, and that's really to coordinate treatment, and that we may include things like psychotherapy and medication management. There's the medical care that our internist colleagues provide to reduce and treat the medical complications, and then nutritional treatment is essential. So our dietitians are really key in our program because they help to establish normal eating patterns and meal plans. Again, we need to consider things like depression and anxiety when we're looking at treating our patients, because when we treat these other things, we seem to have improved outcomes. If someone's less depressed, they're more able to engage in treatment. If they're less anxious and that's addressed, then they can also engage more fully in treatment. And this is often difficult to do because it seems like our bodies don't respond necessarily the same to medications when they're malnourished as when they're fully nourished. So oftentimes we see some improvement with medication, then we see a more significant improvement with renutrition. In terms of medications have been used for a long, long time in terms of treating eating disorders, and there is some good evidence for using antidepressants in bulimia nervosa, and it can help to reduce binging and purging behaviors, but it's not the only thing. If it was used in isolation to treat bulimia, it wouldn't be very effective, and the effect of it would probably wear off over time. But coupled with some self-help or therapy or other more intensive treatment, it can be quite effective. In terms of treating anorexia nervosa, there's not a great deal of good evidence for the use of antidepressants except when people are weight restored, as well as treating their comorbid anxiety or depression. Antipsychotics have been used for about 50 years, for about as long as they've been around, for treating eating disorders, and the primary reason for using them is that they're sedating and they tend to make people gain weight. So we've hoped over time that we can find an antipsychotic that might actually address some of the thinking patterns that go on for people with eating disorders, try to change the body image distortion that happens or the preoccupation. Our medicines aren't that specific, and so we don't have really robust findings that actually happens, but we know that the antipsychotics can be sedating and they can help people reduce their anxiety and their distress when they are trying to gain weight. Anxiolytics, so medications like people might have heard of Ativan, or the old school is Valium, so they're shorter acting ones. They can be quite helpful for treating anxiety and some of the distress that comes up around renutrition. But we always try to be really careful because they're medications that people can become dependent on, and they're medications where you can start with one dose and it works, and then after a while that dose doesn't work, and so you need a little bit more, and people can very rapidly get to fairly high doses of that can be risky because, again, they're sedating, they can slow down people's breathing and things. So we try to be very careful with those. And there's other medications that we use that might be more specifically targeting other mental health issues, someone who has bipolar illness who might need a mood stabilizer, or someone who needs a specific kind of anxiety medicine. We would use those in those situations. In terms of therapy, there's a number of different therapies. I think in the psychotherapies there are something like over 200 kinds of psychotherapy because everybody who puts their own twist on things puts their own name on it. But in terms of looking at the basics, Cognitive behavioral therapy is one that's been shown to be very effective for bulimia nervosa and has been adapted for eating disorders in general. And what that kind of therapy is looking at the cognition, so the thoughts and the behaviors, and how that's attached to mood, and how if you try to look at changing thoughts and behaviors, you can have an effect on mood. It's a very powerful kind of therapy. It's one that people can do on their own or guided, or they can do it with an individual therapist or in a group therapy. Interpersonal therapy is really directed at treating depression and looking at changes that might have happened in a person's life, such as a role change or grief. And it's a therapy that is typically delivered in an individual, and there's been some good evidence that it's helpful in bulimia nervosa again. Motivational enhancement therapy is a therapy that was developed in the substance use disorders field, and it's one where you look at how to help people understand what their disorder does for them, and then look at how they want to change and trying to meet people where they're at rather than enforcing treatment. So it's not about not treating, it's about understanding where people are at and then saying, okay, so where would you like to go? How do we do that? What are the pros and cons? And we do some motivational enhancement, or we call it contemplation therapy, within our program, and a lot of the research that our psychologists have done is around this kind of therapy and integrating it into eating disorder treatment. Dialectic behavior therapy is sort of a modification of the cognitive behavior therapy, but it's looking at how do things happen between people, and how do those responses and reactions between people then affect mood. And if you learn more about how that happens for you and what your responses are, then you can alter mood and you can learn how to do different things. Psychodynamic psychotherapy, that's, coming all the way back from Freud and on, and it's a way of understanding things by looking at old patterns, looking at old relationships, and how we all respond to people based on what we've learned in the past. And then supportive psychotherapy is a form of really trying to support the person's strengths and helping them move forward. So these are all a number of different therapies, and as someone who does a lot of psychotherapy, I use little bits and pieces of all of these when I see patients. I'll just briefly touch on our program. So our program is here at St. Paul's is the Provincial program, which provides the highest level of care for patients with eating disorders throughout the province. We really have a very specialized and comprehensive assessment and treatment planning that happens for each of our patients who comes to see us. And again, research is integrated into the assessment process as a way for us to develop our program. We have a specialized inpatient unit that's over in the Burrard building, and we have a 7-bed unit, 7 to 8 bed unit, and all patients are admitted under a psychiatrist, and then the internists see every patient and follow every patient on our inpatient unit. So Dr. Rauzus and I are the physicians who are primarily responsible for the care of the patients, and then Drs. Rosenbaum, McKay, and Arseneau take turns in rotating through our program, getting to know each of the patients and assisting us with the medical aspects because they are very complicated. We have a multidisciplinary team. As I mentioned, we have a lot of different people who sit on our team and help us coordinate the care so that we really come at it from all different angles. And our inpatient unit really is focused on providing care for the sickest patients in the province and really looking at medical and psychiatric stabilization. For some patients, that might be a relatively brief stay. For some patients, that could be a long stay, depending on where they are in their illness. We provide a number of outpatient groups. So when patients are initially assessed, they are invited to attend outpatient groups that include educational groups for both patients and their family and friends. We also have group therapy that is directed at helping them understand eating disorders and learning coping skills, as well as running some meal support groups. And I always use the term meal support thinking that everybody talks like that. But what meal support means is that there is a staff, and it could be when they come to the outpatient meal support, it's one of the dietitians who arranges for people to come in, bring a lunch, and she sits and has lunch and sort of normalizes the setting and talk is about things that exclude weight and shape and food, and it's trying to have an atmosphere of having sort of a normal lunch together. So we do meal support on the unit as well. There's always a staff person who sits with the patients and has their meals with them. In terms of outpatients, there's also psychiatric care for all of the patients. Every patient that comes through our program has a psychiatrist who may see them quite frequently or may see them only periodically. They come to internal medicine clinics as necessary, or they follow up with their family physician, or sometimes both if they're from a distance away. Dr. McKay and I do the complex care clinic, which is meant for patients who've had chronic illness, chronic eating disorder, or have medical illnesses or other psychiatric illnesses that really make their care a bit more complex. So Dr. McKay has one of the dietitians in her side of the clinic, and then I have one of the nurses with me, and the patients go back and forth between the two of us, so they get to see a team of people when they come in for appointments. We also have the Community Outreach Partnership Program, which is a collaborative program with Vancouver Community. And patients work with a community eating disorders counselor who can help them set goals and help them do a variety of things that can be around eating or can be around quality of life within their own community. We also have a day program that has a residential component attached to it, and it's a very intensive treatment that is very psychologically based. People live at the house for the duration of the treatment, which is 12 to 15 weeks, and it's a very recovery-oriented program, so people are working towards getting to a healthy place, working towards eliminating the eating disorder behaviors from their lives, and again, they have a multidisciplinary team, and they do a lot of group-based work as well as individual work. So in terms of meeting provincial needs, we collaborate with BC Children's Hospital. I was just there last night talking with a group of parents and their children who are being treated. We collaborate with our regional programs, and Dr. McKay and I are trying to do more of that and heading out to other regions of the province. We're doing educational outreach. We have video conferences that occur on a monthly basis, and we rotate who does them from what site. We're looking at doing some clinical outreach. I went up to Prince George not long ago to do some assessments, and Dr. McKay and I are going to head over to Victoria and then probably the interior and who knows where else. And then we do telephone consultation. The internal medicine team are invaluable. They provide coverage 24 hours a day, 7 days a week, so that they are always available. If somebody in Stewart, BC admits a patient, they can call the internist to say, what do I need to do? How do I do this? And we know from the feedback we get that it's incredibly valuable.